Welcome and good morning to our first keynote speaker. My name is Debbie Begay, and I have the pleasure of introducing Mr. Tom Perhson. Mr. Perhson is the North Region CEO for Intermountain Healthcare. He oversees 5 hospitals. He has 24 years of experience in healthcare leadership, both in hospitals and health plans. Under his leadership, using the lean manufacturing principles known as continuous improvement, he has significantly improved 3 hospitals in the state of Utah. Mr. Perhson received his degree in history from BYU and his master's in healthcare administration from the University of Michigan. And I'll now turn the time over to Mr. Perhson.
That's a very tepid clap. I know it's because I graduated from BYU. You know, I see a Ute here in the front. It's sort of distracting to see that. But glad to be here with you. And this is a great university. I have a lot of love for Utah State, particularly when BYU beats them. So that's always good. That doesn't happen very often anymore because BYU is not very good. All right, well, let's jump in here. Wanted to just talk a little bit about Intermountain Healthcare. For those of you who are from Utah, you might know some of this. Those of you who aren't, I'll give you a little perspective on it. So Intermountain Healthcare is an integrated delivery system. It has 22 hospitals, primarily in the state of Utah, one up in southern Idaho. Significant organization. It's about $6 billion in annual revenue. And we have a health plan that has about 1 million members, and then a significant employed physician medical group. Our mission is to help people live the healthiest lives possible. And our vision is to be a model health system by providing extraordinary care and superior service at an affordable cost. And in the North region, where I'm responsible for these 5 hospitals here. One is actually under construction in Layton. And we're about $750 million in revenue. We have about 150,000 health plan members in this geographic area and about 250 employed physicians. We also obviously work with lots of independent physicians as well. So I wanted to start out by telling you that I know that the last time that you went in for some sort of healthcare procedure, you probably got the bill maybe 2 or 3 months later. Not really good flow. And you looked at that bill and you said, wow, that was a lot of money. We know that. We know that there's a lot of problems in healthcare, and it's beyond just the costs. So we have lack of standardization in patient care, creates all sorts of problems. Physicians doing different things differently on patients for no real reason other than it's the way that they were trained. We have many clinical procedures that don't necessarily produce better outcomes. So we're doing stuff on people that there's no evidence it actually works. Also, we have unacceptable rates of preventable harm that occur to people when they come into our facilities. If you were to get on an airplane with the same safety record that we have in healthcare, you would not get on the airplane. You would be that scared. So we've got significant problems with this. There's tons of waste. Again, you can see that just when you go in and get a procedure. You can see it both in terms of dollars as well as your own time. And finally, we have a system where there are many Americans who do not have insurance or access to healthcare services. So we have significant challenges. I mentioned cost problems just a minute ago. Often we think about the national debt as the big problem, right? We think, oh, it's almost $20 trillion. Social Security, we got to reform Social Security. Its unfunded obligations are $7.1 trillion. But nobody is really talking about the unfunded liabilities that are associated with the government health care programs in Medicare and Medicaid. It is nearly $39 trillion. It's huge. And so when you hear about all the things that are going on in politics and they talk about what we can do, it squarely rests on health care. So we have to do a better job. We have to get better in order for the economy to thrive and be successful in America. Despite all of those challenges that I just talked about, I want to let you know that those of you who live in Utah actually have wonderful health care. We represent about half of the market, so certainly our competitors are part of this profile that I'm showing you here. But Intermountain is a large driver in this, and you can see this comes from the Commonwealth Fund, and it evaluates various different measures, and you can see that Utah and with Intermountain's help is really doing great across the country. Just looking at the healthcare cost per capita, we're the lowest healthcare cost per capita in the entire nation, 43% lower. You can look at those measures below. Here's kind of an interesting little diagram here. If you look, so this is worst health over here to best health, and this is least affordable to most affordable, and these are the states in the United States. And you can see where Utah is. We are the healthiest, and we also are the lowest cost per capita. Again, suggesting to you that we do have good things here in Utah happening, and I think that a lot of it is partly due to this. Before I run this video, I want to just give you a heads up. We produce this for our boards, so it's very happy, and I'm not going to try to sell you anything after this, okay? I promise. But the reason I did this is it's just about 3 minutes that talks about the great things that Intermountain Healthcare has been doing for a number of years around quality improvement and some of the results. So I think it does a nice job of capturing that. So
we have long known that some places like Intermountain Healthcare in Utah or the Geisinger Health System in rural Pennsylvania offer high quality care at cost below average. And that's why we need to build on the examples of outstanding medicine at places like Intermountain Health in Salt Lake City.
Look at the Dow.
Where high quality care is being provided at a cost well below the national average. These are all islands of excellence, and we need to make the standard in our healthcare system.
Intermountain is arguably the most productive single health system in the United States, 20% more productive than Mayo. And this is a result of a 40-year process.
One Utah institution, Intermountain Healthcare, has become a model by finding ways to improve the quality of care and reduce costs.
It was the Mayo Clinic that first
This is
told
a
us
guy
about
in
this
Rochester,
place. They've been
Minneapolis.
researching what really works in healthcare, and they pointed us in the direction of Utah. That's where Intermountain Healthcare is based. They've been doing things differently there for a long time, and it's working, especially when it comes to things like diabetes. In fact, Mayo's CEO told us if he was ever diagnosed with diabetes, he'd want to be treated in Utah.
Utah does have the lowest cost for health care per person in the entire country. Back to you.
And to be singled out like that in the entire nation, what an honor for them.
Intermountain Healthcare featured in the New York Times Magazine today for innovations in healthcare.
The New York Times Magazine profiled the program yesterday with a front page article entitled Dr. James Will Make It Better. The president has singled them out and sent advisors to Utah to learn more. Its advanced training program has become a mecca for healthcare professionals looking to improve what they do. How has Intermountain Healthcare become a national model? Its chief quality officer says the attention comes after many years of tracking costs and patient outcomes and developing new protocols.
We've demonstrated what was well known in manufacturing for many years, nearly always better patient results, much lower cost.
So good to hear that.
Yeah, good to have that model here.
So, again, I told you it was a little happy, and actually we should be proud of it. This is great health care in Utah. Largely, the culture of quality improvement started with Dr. Brent James 30 plus years ago. He came into Intermountain Healthcare and he said, we can improve the processes of care and think about it differently. And his main approach has been, where we've seen the big results, has been kind of in large innovation projects. So how do we care for diabetes and really thinking about that and doing it differently? Or how do we think about taking care of heart attacks or people with heart failure, for example? That really largely has come from Intermountain Healthcare's clinical program. So it was really rooted in the same kind of thinking that is in lean. It just wasn't broad like lean. So in some ways, I come onto the scene, I feel a little like I've been born on third base because I had such a great infrastructure for quality. And while, you know, we're not a distressed organization, a lot of times when people get into lean, they're distressed. We got in it because we thought that it would help us, but we had a framework that when we talked with people about basic principles that you would start in talking about lean, people just said, yeah, of course, that makes sense. Yeah, let's do it. I mean, it's been hard to kind of help them see some of the different thinking around lean, but nonetheless, it's been very beneficial thanks to Dr. James and the great people in our clinical programs. So let me talk about Intermountain's continuous improvement. You won't hear me use the word lean much here. We've expunged that word. People don't like it in healthcare. For whatever reason, I've gone all around the country. Nobody likes the word lean. Sounds like we're going to cut something. We're going to eliminate staff. So we've branded this as continuous improvement. Intermountain continuous improvement is what we call it. And I want to talk to you just a minute about my journey, and then I'm going to talk about some lessons that I've learned. So this started out in 2005 for me. We were doing a strategic planning session in the fall of 2005, and we wrote on a whiteboard that a goal something like this. We want to make sure that everybody comes to work knowing exactly what they can do to help us improve. That was the way we awkwardly wrote that goal, okay? So we finished our goal planning retreat in the fall. We get into the next year, 2006. We pull out all our list of goals, and we're talking about how we can start attaining them. And we look at that goal like, what in the heck is that goal? How are we going to attack this? And I had a management engineer that worked for me. His name was Bart Sellers, and he said, hey, I got an idea. He said, there's this company, and they're in our back door, in Ogden. Why don't you go and take a look at what they're doing? It's pretty interesting. I don't know if any of you have been from Autoliv. Is anybody from Autoliv here? Has anybody been to Autoliv? So several people have been to Autoliv. It's very impressive. They produce airbags for a third or more of the cars around the world, and they have a significant manufacturing operation in Ogden. Anyway, they're great. We went, and I kind of wasn't expecting to see anything spectacular, but what I saw was charts, graphs, huddles, process checklists, leader standard work, recognition, idea boards, project teams. And for those of you that have been there, it's very impressive. You're like, wow, there's something special here. But what I saw below the surface that really caused me to completely rethink the way that I was leading, the way that I was approaching healthcare delivery, I saw this sense of direction, this sense of urgency, empowerment of people, experiencing and overcoming challenges, leaders focusing on improvement and more importantly, their people focusing on improvement, and a culture that was just palpable. And I was converted. I mean, I didn't know what I was getting myself into, but I left with a firm determination that we were going to apply lean principles in healthcare, or at least test it. So, the reason that we decided to move in this direction is it was the only method that would engage everybody. And if you remember, our goal that we came out of that 2005 planning session was just exactly that. And we felt that this is our vision of extraordinary care. We would accelerate the rate of improvement. And if we applied these principles, we were confident we could do it. So we went out, we kind of chickened out, right? Because I didn't want to go into any clinical areas and mess it up. So we said, let's try it. Let's pilot some tools, some continuous improvement tools in room service. And, here's a little idea board. We started out with that. Then we had a simple Kanban system that allowed them to visualize where things were stored, and then some visual controls around food preparation to ensure consistency of food preparation. And, just like you've probably experienced when you've utilized lean tools, it worked. It's pretty cool. And so we became very reflective. We started going around to different organizations, both in and outside of healthcare. We talked to some consultants and got perspectives. And it was interesting as we talked with people, there were two different fields of thinking in terms of, all right, what are you going to do to roll out lean in your organization? One was a project focused. And often many of the consultants were coming here and saying, yeah, we can come in, we can do some projects. And we knew that they would work because we saw it just based on using those CI tools in our food services that they would work. But it's not a lot of people involved. The improvements are top down and they sort of level out. I mean, you're going to see good improvements, but it's not going to be that exponential improvement that you'd like to see. The other alternative is to kind of look at this cultural focus. It's probably a little bit slower. It's really focusing on broad involvement of the front line. It's a belief that people who are doing the work actually are the ones who can improve it. And so therefore you have to create a culture that facilitates their involvement in improvement. It's focused on systems and processes. You certainly use lean tools and techniques, but they're not the emphasis. And improvements really come from everybody, and they increase exponentially over time. So we really were very purposeful in saying we want to do the cultural focus, not the project focus. And so we probably taken a little bit longer, although as I've learned, just lean in general is a journey. It really is a hard learning process that just takes time. So we then said, all right, we're going to pilot a comprehensive management system. It was more comprehensive than, it wasn't comprehensive at the time, but we thought it was comprehensive. And the signature feature of this was that there were huddle boards. We were asking everybody to huddle before a shift and understand what was going on. And then we had an idea system in each of these areas. And these were in food services, again, surgical. We actually tested some things out in a clinical area, and supply chain. And again, we just saw really positive results. And here's that, what I called the flying formation, which is that method. You can see it's okay, but it's not fabulous. At any rate, what we learned is that it actually can work in healthcare. We don't have the same inputs that maybe a manufacturing because they're variable, but by darn, the principles really work, and they work very well. So I wanted to just share with you a couple of things that were aha moments along my journey. So at McCady Hospital, it is a certified stroke center. Sounds kind of important. The accrediting body for most healthcare organizations is an organization called the Joint Commission. And if we're not Joint Commission certified, generally speaking, you're not going to be able to get payment from the insurance companies, and particularly Medicare and Medicaid. There are some exceptions, but generally speaking, that's the case. If you want to do stroke really well and become a stroke certified center, you become a Joint Commission stroke certified center. So we just had our stroke certification from the Joint Commission, and they came back at McCady Hospital and said that there were 0 findings, meaning that they thought we were amazing. Okay, so I'm talking to our stroke leader, Chrissy. She's telling me, why do I need to do continuous improvement? You know, we're doing really well. We're certified by the Joint Commission. That's the best standard you can get. Why do we need to do that? And I said, just please do it. You know, and so she ended up doing a value stream map of their process. And that's usually kind of advanced. This was a few years in to our lean journey. And so she did this value stream map. Guess what she found? A lot of storm clouds, right? And this was a shock to her. She's like, I can't believe this. And I mean, she did believe it because she did the value stream. But anyway, she ended up working with a team of physicians and nurses that addressed many of these storm clouds. And what we saw is, so when you're coming in for a stroke, they have to determine if it's a clot or if it's a hemorrhage. Because if it's a hemorrhage and they give you this clot-busting drug called a thrombolytic, it will kill you because you're already bleeding. You don't need to bleed more, right? So door to CT time to see if you have a hemorrhagic stroke is really important. That decreased by 43%. The average door to needle time decreased by 30%. Initially and eventually the percent of people receiving this thrombolytic TPA in under 60 minutes went from 11% to 77%. Now, obviously, we still got room. We want to make that 100%. Just so you know, the gold standard in the industry is 50% of the people get TPA within 60 minutes time from presenting to the emergency room. For those of you who don't know much about stroke, you have 3 hours from the time of onset to get this thrombolytic in, or you have dead brain. Usually you can completely recover from a stroke if you get a thrombolytic. So this is a very important metric for us to look at. That came because of continuous improvement, because of their effort to focus on the processes and see how they can improve things. That was one example. Here's another example that I thought was really empowering. So, as I mentioned earlier, Intermountain Healthcare has these clinical programs, and one of those clinical programs is in heart services. And they had developed some training for heart failure for patients. It's a self-care model. We call it MODS, medication, activities, weight, diet, and do you remember what the last S is? Anyway, the last S is something. And at any rate, we weren't doing a great job of teaching our patients at the time of discharge and who came in with heart failure. And so what was happening is these patients were coming back, being readmitted, which is bad. You know, rework is bad. And second, it was costing them money. And then pretty soon Medicare started saying, hey, if somebody's readmitted after 30 days from a diagnosis that you treated, we're not going to pay for it because you guys didn't do it right. So all of a sudden it became financially important, and we saw that we needed to change. So the manager was talking to her staff and he said, hey, McCady Hospital is the worst in the system, the Intermountain Healthcare system, for heart failure readmission, and not very good in the country. And so they had an idea board, and a frontline employee Sharon Barney, this is the actual idea board that spawned a whole series of great project work. She had an idea about how to change the way that they did some teaching, which resulted in some standard of care checklists, which resulted in care processes developed around 13 specific diagnoses that people come in, which resulted in lots of teaching tools, risk assessment tools, decision process in collaboration with our clinical programs to design something better. And as a result, McCady Hospital went from, one of the worst in the country to the third lowest readmission rate for heart failure in the entire country. And, a principle for continuous improvement is this idea of lateral deployment or spread. I'm not going to use Japanese. I tell my people I'm not going to use Japanese. But that information was spread through our clinical programs to other facilities, and then we had several other hospitals in our system that became the top in the country as well in heart failure, and that's remained that way since 2012. So again, here there was a frontline person who knew the work best that came up with the idea that began to spawn all sorts of great work that resulted in terrific outcomes for our patients. Here was another one that was a great staff satisfier. So sometimes that you do these spaghetti diagrams, and this is the emergency room at McCady Hospital, and these are various different zones. So this is the way the physicians and the nurses and the techs kind of think about this. So this is just for suturing patients. So the red line is the tech, the blue line is the nurse, and the green line is the physician. So you can see they're going back and forth and back and forth. If any of you have been to an emergency room and had to get sutured, often this is the case. People coming in and out, in and out, in and out. It's very silly. We look like we don't know what we're doing. So they evaluated this. They said, hey, let's purchase some suture carts, create some standard content. We can move these around. We'll have 2 or 3 of these in this large emergency room. And then when we have a suture, we're going to bring this in, and everybody will be able to come in and make one seamless flow. So it went from this to that. 737 steps to suture someone went to 84. It saved 15 minutes per procedure. And obviously it was a great satisfier to physicians, staff, and patients. That represented 14 and a half days of time that people were wasting walking back and forth. That's 38.2 marathons that the staff, were going on. Now, obviously, we're into living well. We want to encourage people to take steps, but we don't want to do it in a way that's wasteful. And so this was a great satisfier. People began to see, wow, this stuff really works. If we think about flow and we think about processes and designing things differently, we can make a better experience. Now, you can imagine it was a great satisfier for physicians and staff, but the patients, he actually knew, it looked like the people that were caring for him knew what they were doing instead of running in and out, in and out, in and out. So, the whole purpose of Intermountain Continuous Improvement is it's a method to engage all staff, leaders, and physicians throughout the system to systematically increase value to you, our customers. That's the purpose. That's our vision. We saw many accomplishments throughout the last number of years, just at the 4 hospitals in the North region that are in existence, and the 5th one that's being built. We're designing it with many lean principles being built right into it. But we've seen many quality improvements. I talked about one of those. We have 45,000 implemented employee ideas since 2009 when we formally rolled things out. And you can imagine those first 2-3 years, we weren't getting a lot of ideas. We were getting way more than we had. Now, I'm really proud of that number, but then when I go to Autoleave, I look at their ratio. We're about 1.5 ideas implemented per employee per year. and they are one implemented idea per employee per week. So they're very mature. But we've got world-class employee engagement. Believe it or not, the engagement went through the roof. And recently, the rest of Intermountain, as they've started adopting these principles around huddling and so forth as we've begun to roll it out, because I'm now also responsible for continuous improvement throughout the system, we're starting to see some significant improvement. But initially, Intermountain was about 7-1. So this is actively engaged to disengaged. And you can see that it was almost 13-1. National best practices is 5-1. And it proved to me that when you get people engaged in being problem solvers, they really get engaged and they love their work. And they do great things. And again, we've seen that. We've seen great service outcomes as a result of this based on some national surveys that are done. And we've had millions and millions of dollars. And I hate to put a number up there because it's always changing, but you know, it's in the neighborhood of cumulative savings of around $70 million, not including this year. So things have really been benefited as a result of this continuous improvement efforts. What we learned, or our conclusions, is that the concepts work in healthcare and every process can be improved. There was a situation where one of our hospitals had a average length of stay that was one of the lowest in the country, meaning we were able to care for patients, get them out and not readmit them again, and get them all the care that they needed, which means lower cost for the patient. And I would have never started there as a place to go after things. But because the frontline employees were engaged, they shaved a half-day length of stay out of that already nation-leading performance on that. Just really impressive. Improvement is exponential. You know, it's always so tempting to get excited about going after costs. But if you just let the people see where they are, they will make improvements. And it will be powerful because you have 5,000 brains working on this instead of a handful of them. Leadership behavior creates culture. I'll talk a little bit about that. But what we do as leaders is important. And we can create a culture where improvement is encouraged at the front line, or by virtue unintentionally, it's discouraged. And finally, it just takes time. So, check my watch, see how I'm doing on time. So lessons learned. These are some major lessons learned. If you're thinking about doing continuous improvement from the very beginning, these are my thoughts around that. Number one, build leadership support. Now, if you're not in a position of leadership, that is a senior leadership, if you have your senior leaders on board, this really helps a lot. Okay, I know that because I started out as the senior leader for my region. And it was hard, but I was able to create a consistent message with my leadership team. I'm now in the process of doing this for the entire system. I'm not the CEO of the entire system, so I'm doing a lot of that by influence. It's a lot more difficult, but it's still possible. So where you sit, where you stand, you can do this with your own team. And what will happen is people will come in and start looking and saying, wow, why are you getting all these great results? And then pretty soon you begin to share that and it grows organically. That's actually why I'm involved doing this for all of Intermountain too, is because my leader came in and was like, wow, this is neat. And then she asked me to do it more broadly. So build leadership support wherever you sit. Build leadership support. I find that the best way to do that is to go out and see. I mean, we went to all over the place. And usually in your communities, there's somebody that's doing this really well. So you don't even have to travel. You know, we had Audley, we had US Synthetics, we had OC Tanner. But we didn't really have any great examples in healthcare. So we did travel. You know, we had to go around. There were just a handful when we started. There weren't very many people doing this. But that helped me build people's ideas of where we could be and what we could do. Because I needed my whole team, even though I was the CEO of that whole region, I needed my team to really buy off and do this. So this was really important. We went on visits, we put hard hats on, and we learned a ton of stuff in the process of going out and seeing that we were able to bring back into our own areas. And so it was great. It was wonderful. So build leadership support. It's absolutely critical. The second thing is language matters, and you need to connect it to your culture. So I don't know what your cultures are from your businesses. I told you that people in healthcare don't like the word lean. They also don't like the Japanese words, and that's no offense to any of my Japanese friends out there. But, there's a feeling, hey, we live here in America, we're healthcare workers, we're professionals, let's just use our language. So that's what we did. I started out talking with my people. Does anybody know what this is, by the way? Besides a really cool picture? What's that? Nope. Aliens descending? Yeah, that's a good thought. This is Mercury, Venus, and Saturn, perfectly aligned at the top of these Giza pyramids in Egypt. It happens once every 2,737 years. And the last time that this happened was December 3rd, 2012. Those planets were perfectly aligned. And what I've told my folks is that Intermountain Continuous Improvement is perfectly aligned with our vision of delivering extraordinary care. And so what we've tried to do is we've tried to tie it to everything that we do. I talked about clinical programs. They'd been in ground for a long time before us. We weren't going to bowl over and say that we're doing this better than you. We're going to say, hey, you're doing exactly what we want you to do. Let's take some of the continuous improvement principles and apply them here, and we can help you spread more of the knowledge that you're gaining in these clinical best practices. We had a process around thinking about zero harm. We want to reduce the harm to our patients. Rather than going out with this big different program about zero harm, we said, no, these are the same thing. Let's call it continuous improvement, zero harm. We talk all the time about our mission, vision, and values, and we point people back to how continuous improvement helps us achieve these things. And so it feels very natural for people. It doesn't feel like it's the flavor of the month. It doesn't feel like it's the next thing. Of course, we built a house just like you all do when you have a lean journey. But you can see, these principles were taught by Dr. Brent James. They're lean principles. We have the continuous improvement method. That's where we kind of come in. You see standardization. That's our clinical programs, clinical services. Then we've got zero waste, zero harm. Just in time and first time quality, engaged employees. And this is the how we deliver our vision of extraordinary care. That's what we talk to people. This is how we do it. And that has been very synergistic. You've got to be able to do this in your organizations if you want to have success. The next lesson learned here is that continuous improvement framework or method needs to be developed. This was our initial one. Later, we created something that I believe is much more elegant. We call it the Intermountain Continuous Improvement Method. You can see it has 7 key systems. Under each key system, it has several key elements. I'm going to show you quickly what I mean by that. And this is the key, is that these key systems and elements of this continuous improvement method help leaders create the culture of continuous improvement. I was just with the CEO of Bear River Hospital yesterday, and he said, I've been an executive for a lot of years, and I've never been able to figure out how to create this culture until we started using the continuous improvement method. He does report to me, so he might have been brown-nosing a little bit, but I believe that it's represented in his organization. So let me talk a little bit about each one of these key systems. So I just want you to see the complexity of it and why it's important to set this out, and then I'll come back and talk about why we did this. So strategy deployment, what does it mean to be successful? It's really clear expectations at every single level in the organization. Often we have clear expectations at the top, and the people down in the bottom and the middle don't know where the heck we're going. How are they going to know how to improve if they don't know what to improve? And so this is really an important thing. There's various different key elements of this key system strategy deployment. You can see lots of these. This is a picture of a huddle that's happening at LDS Hospital, and both a huddle and a huddle board are part of this strategy deployment process. The key system of visual management, how do we know that we're successful? These are systems and processes that are designed to help staff see problems in real time. Again, here's several different key elements, but here's some metric indicators and some process signals. This is down in the surgical unit at McCady Hospital. You can see some living Paretos that are going on. You can see clearly that they know when they're on track or not. And then this is a visual process that I'll talk about at the end of my speech around sepsis and keeping our patients safe through that process signal. Daily improvement. If we have gaps, what are we doing about them? And this is where employees are engaged through team-based problem solving, idea generation, and recognition. Here's an idea card that you see here at Park City Hospital, and here's one example of an idea board. We've given people a lot of liberty in terms of what it looks like so they can be creative and have fun with it, but there's going to be certain elements that we're going to want to see that are there. Key system of closing the loop is, as a leader, how can we help you be successful more often? And we need to be engaged in reaction protocols, coaching, and standard follow-up. This is really important. If you don't have this process in place, all of this will fall apart. One of the things that we've implemented recently is this idea of tiered escalation huddles. You can see that it starts here at the front line. This is representation. They escalate issues that come up to the organization, and then obviously management support provides support on any action that might be needed. This has really helped close the loop on several things, particularly around safety issues in our organization. From a problem-solving key system, how do we approach problems? We have to have consistent methodologies to approach problems and engage teams in scientific problem-solving. The thing that's really cool about this continuous improvement method is that it forces the leaders to use the scientific method for problem solving in their specific areas and engage their teams in that scientific problem solving process. And here's some examples of some living Paretos that are on the physician clinic office in their area. But we want to have common tools. We want people to be involved. 100% participation is what we call it. Value improvement projects. So these are kind of the big breakthrough. How do we achieve large innovations? And we're going to use tools to innovate and create breakthrough approaches that will increase value. These are things like the clinical program initiatives that I was talking about. Also, we build hospitals and clinics, so how do we make sure that we think about flow before we build it, doing 3P events and so forth. And then the last key system is best practice integration. It's how do we learn from one another? And it's a method to prioritize and share, track applications, lessons learned. One of the things that's not really in this key system, but I think is probably one of the best practice forums, is that closed loop system in doing what we call step back reviews, which allows the organizations or allows leaders to go down into the organization and see what's happening. And because you're actually there seeing what's happening in multiple areas, you then get to spread that out to other areas. I've just been doing step back reviews for the 4 hospitals that I'm responsible for. I'm going up to Kaja actually right after today in Burley, Idaho, and I will share things that I learned at Logan Regional Hospital and at the other hospitals. But this is a heat map that we've developed. It's a tool that allows us to kind of look at safety, quality, flow, engagement, cost. It then has a mathematical formula that allows us to see that it's either high difficulty, high impact, low difficulty, low impact, and it allows us then to kind of as a leadership team to say, hey, here's some projects that are happening. What can we do to laterally deploy those in other areas? And then obviously you need some sort of a tool to help make sure that you do that. These are just some examples of deployment process that we've used. So in summary, the reason that you want a continuous improvement method with its associated key systems and elements is that it allows you to have a common language. This has been really important as we've been bringing this out to the rest of Intermountain Healthcare, because you saw it's a $6 billion organization from southern Idaho to the bottom of Utah. And so being able to have that common methodology where our CEO of the system can get up and speak consistent language is becoming increasingly important. The other thing that it does is it provides a framework for leaders to assess the culture and the performance. And it allows us to kind of take segments of that and assess how we're doing. In fact, we've created these assessments. This is just an example of some of those assessments, electronics. So this is strategy deployment catchball. We have different levels. So basic level, level 1. So leadership has a counter to support the catchball process. Each level has input into the higher tier goals. Managers involved, directors' goals, et cetera, et cetera. You go down into the strategy connection tool, and you've got level 2 changes or assessments that we can go in. So we can go in and kind of quickly do an assessment of how we're doing and create a heat map, and then as a leadership team, at every single level in the organization as a leadership team, we can have conversations about, hey, we're not doing catchball very well, or we really need to think about our lateral deployment process because we're really weak in this area. It's been very helpful for us to get our heads around how to improve with the methods so that we can get better. So that was lesson learned number 3, which is to create a method or a framework for your area. The next lesson learned is, where do you start? Okay, if you're starting this thing out, what do you do? My recommendation based on several years of experience is start with frontline huddles, huddle boards, idea systems, and step back reviews. Part of the process of coming up with a huddle is that you're going to have to do this strategy deployment process because you're identifying what matters most in those areas. So I could have added strategy deployment. You can see these all sort of are interrelated. But these things are absolutely critical to beginning to get some early wins. Because you will find, here's what I found. When I started doing huddles, everybody complained like crazy before we did them. Why do we have to do this? We're so busy. We don't have time to start the beginning of every shift talking about what's going on. You're crazy. This is stupid. It's never going to work. 2 weeks later, when he said, I don't know how we ever did our work without them. And I found that universal in multiple sites across Intermountain Healthcare. And because they work. Teams actually get together and huddle and talk about the day, and the day goes better magically. So, and then the important part of this, you can implement all those, but if you as a leader never get out and get into your organization and see what's going on, it will fall apart. This closed loop system is really important, the step back review concept. So get out and see what's going on, get a regular rhythm, and you'll find that it makes a big difference. Okay, my last point in terms of lessons learned is a leader's role. I mentioned at the beginning of my presentation that the reason that we did continuous improvement was to get everybody involved in improvement. If we as leaders act like eagles, big, beautiful, I'm really cool, I do a good job, I am really smart, and I see a problem, I swoop down and I fix the problem. Then I swoop back up and I'm really feeling cool about things, right? Does that create problem solvers? No way. You've taken away their incentive. They don't care anymore because they're like, well, somebody else is going to fix this. Why should I care about it? And the worst of all, they actually might implement your idea, which is going to never work because you don't know what you're doing. Your responsibility of a leader is to create the culture where everybody's involved in improvement. And if you are a swoop down leader, if you're an eagle, you're destroying your culture. You may not think it, and you became an eagle because you were really good, right? You were a good problem solver. At your level, you could problem solve. That doesn't work. It only works this much. But if you want 5,000 brains instead of 2 or 3, don't be an eagle. Be geese. What's important about geese? They work together. They can fly thousands of miles. The person at the front will often be in the back. When that person in the front gets tired, the person in the back just comes up, the goose comes up and takes the lead, and they just keep going. They work as a team. They have a system. They have a method that drives superior performance. And we as leaders have to realize that our responsibility is to create a framework, a method that culture can thrive. We found that in our Intermountain Continuous Improvement method, and I think you can find that as well. So again, here's these lessons: build leadership support, language matters, connect to your culture, develop a continuous improvement method, start with huddles, huddle boards, idea systems, and step back reviews, and think about your role as a leader. It's absolutely critical. Let me end with this story and why this is important and personal to me. There is national best practice data that shows that if we, with patients with sepsis, which is a bad bloodstream infection, if you've got sepsis, you're a really sick patient and there's a high mortality rate associated with it. You could die if you have this. But there is a bundle of care that you can receive, and if you get that bundle of care at a certain timing, your likelihood of survivability is significantly better. So the country is about 15% implementing the sepsis bundle. Intermountain Healthcare is about 30% when we started doing this back in 2014. We talked with our nurses and physicians and they in the ICU, and they said, hey, we can't tell timing. We can't see it. So using visual principles, visual management, they created this magnet that they put outside of every door. So you walk down the ICU, you can see where everybody is exactly timing. That bundle went from, adherence from bundle went from about 30% up to 70%. In the 2 years, that was a difference of 35 lives walking out of our hospital alive. You have ways to make that kind of impact in your areas. Now, I will say, incidentally, that some of the bundles have changed, and we haven't adapted as quickly, so we've got a return to green plan on how to get back to that. We implemented a new electronic medical record, which has helped create some confusion around the timing of these things. But I'm confident that we will get back to where we need to be with the sepsis bundle because of this continuous improvement method. So thank you very much. I'm happy to take any questions.
All right, we'll now open up questions to the audience.
Yes.
You mentioned a great point about building leadership support. Could you just repeat that real quickly? I just want to make sure I understand.
Yeah, so building leadership support is critical because if you don't have their support, you're not going to be able to do it. You're going to have a bunch of people acting like eagles, and you're not going to have this nice formation of geese that are going to help you drive your organization. So the way that you do that, I find the best way to do it. I mean, we read books together. We went and saw stuff. But ultimately, just start doing it and experimenting, and that helps begin to build support. But when they see, first of all, people will be skeptical, so if they can see it working somewhere else, I think it's very helpful. Yeah.
How did you engage or involve the physicians?
Oh, that's a whole nother speech. I didn't start until 2012 because I thought, I can't let them see us screw this up. Because they're a little cynical anyway sometimes, towards administration. So we kind of kept them on the sidelines. But after a while, what we did is I actually just took 2 lead physicians up to Virginia Mason and Seattle Children's, and they saw some great things there, and they came back energized and said, we can do this with physicians in our area. And then it was a process of creating some physician champions, and then taking those other physicians that they were interacting with up to Seattle children. For a year and a half, we were going up to Seattle 8 times a year with physicians, taking them up just to see what the possibilities were. And then we started getting, it was amazing. I knew when we had started to arrive because I was sitting at what's called a medical executive committee, which is the physician department chiefs of a hospital. And they started saying, hey, I'm going to put together a committee, a continuous improvement committee for my area in OBGYN or in heart. And the others, oh, that's a good idea. I'm going to do that. And, you know, the ball started rolling. So, questions?
What's your continuous improvement team structure, and how do you manage multiple facilities and have the resources to help everybody have this goal of change?
Yeah, so again, the key to our focus on this is that we didn't want to build a big continuous improvement team, because then everybody says, well, that's your job to improve. So we have, for the 4 hospitals, we have 10 people that are employed full-time doing continuous improvement. Some of those are engineers, some of those are just people helping in education and training and so forth. So, but the emphasis is really the leaders. You as leaders are responsible to create this culture. And so where they come in is they'll come in and help us on specific projects that are complex, where we need to work on one of those big projects. And then from a system perspective, we have 8 individuals that are at a system level, that their whole responsibility is Intermountain continuous improvement, and they help go out to other regions. There's 4 other similar sized regions to mine, and they go out and help their team of 10, or in the case, it's based on size and scope of the organization. So we've created an algorithm that says you need this many people based on your subtotal expense. And so that's kind of how we've organized.
We have time for one more question from the audience.
Yeah. Sure. Say that again.
So the heat map you talked a little bit about, I mean, that's pretty complex.
Yeah.
Can you talk about the evolution of that and kind of how you guys
Yeah, it was interesting. So my CI director and I were talking. We kept saying we got to do something on lateral deployment, and he was bringing up ideas, and I'm like, Scott, I don't think that's not the most important thing. I can't get my team to buy off on that. So we actually just sat down. 3 or 4 of us sat down in their big whiteboard area and mapped out some things. And then I left, and they actually got the smarts in the room and created the framework to have a balanced scorecard, and then created the algorithm behind it that allowed to create that tool. So that's how it happened. We threw all the improvement projects that we were doing into that, and then scored them and said, oh, does this make sense? You know, we stepped back and looked at it. Does this make sense? Yeah, this makes sense. So we kind of knew that this was the right thing. Now, it doesn't, just because it's at the top of the list doesn't mean we're going to do it, because we'll say, you know what, the timing on that really isn't right, but, you know, we're going to avoid going to the bottom one first and trying to laterally deploy it. We're going to be up in that top quartile of things. And then as a leadership team, we bring that to the executives of our leadership team. We say, all right, what do we want to laterally deploy? And then we have conversations about that and create plans. All right. Thank you. Been a pleasure to be with you.
We'd just like to thank Tim Perhson for coming and for teaching us again that these principles not only help improve organizations and companies, but also help to save lives. So thank you very much.
Thank you.
We're now going to take a short 10-minute break. There's coffee.